Hello, my name is Dixon Naish and I'm a Senior Analytical Chemist here at Intertech Melbourne, and welcome to this presentation on new in vitro bioequivalence approaches for generic nasal suspension products. Firstly, today we're going to look at why in vitro bioequivalence studies are a viable and exciting new path to registration for generic nasal products. We'll then briefly describe the techniques we'll use to characterize the particles and produce size distribution for bioequivalence, and this will be followed by an introduction to the case study we performed here at IM, and lastly, a brief look at the conclusions from the study. So firstly, let's take a look at what an IVBE is and why they're a good alternative to a traditional clinical endpoint study. So we know a generic product needs to demonstrate bioequivalence with respect to the reference product. And historically, this has been completed by a combination of a clinical endpoint study looking at PK and PD with supporting evidence from in vitro studies showing that the products are qualitatively the same, which is Q1, and quantitatively the same Q2 bioequivalence with limited Q3 study. And we'll come back to Q3 in a moment. However, these in vivo studies have drawbacks. The requirement for a patient increases the safety risk, and these endpoint studies have a fairly long timescale, and all of this means they're relatively expensive. So how about using an in vitro only approach for generic nasal products? So this new approach was triggered by a successful approval of a mometasone furoate product, which demonstrated Q1, Q2, and Q3 equivalence by using this weight of evidence statistical approach that bypassed the need for a traditional in vivo clinical endpoint study. So to prove we still have bioequivalence, we have to increase our Q3 component, which is looking at the physiochemical attributes of a specific dosage form and looking at the particle size distribution and the particle characterization. Therefore, to be able to do this, we must be able to characterize all our API particles to prove bioequivalence. And this gives us some benefits. We have a shorter timescale, and no patient means we remove the safety risk, and this overall lowers the cost. So we're now going to take a brief look at our primary and orthogonal methods, and we're going to start with our primary, which is morphology-directed Raman spectroscopy, or MDRS. This uses an automated optical microscope analyzing many size and shape parameters of the particles. It captures images of particles and determines the morphological parameters of these particles, including shape, size, and some transparency parameters, and can analyze both dry and wet sample preparations. Particles are filtered from these parameters to remove most of the excipient particles, and is best for removal of large particles where morphology differs the most. And then we use Raman spectroscopy to confirm the identity of the filtered particles by comparison to the reference spectra, and this is very effective for removing the remaining excipient particles with similar morphology to the API. From this, we can generate a particle size distribution as a number-based distribution, but we do have a limitation with this technique that we can't see below 0.5 microns due to a limit with the objective at 50 times zoom. So to get around this, we're using an orthogonal laser diffraction method. And this is a popular technique for wet and dry sample preparations, where the sample passes through the laser and the sample particles diffract the light at varying angles and intensity based on their size. However, these results are based on the whole sample. We don't have the filtering available between the excipient and the API, and the instrument sees the sample as a single component. From this, we get a volume-based particle size distribution, and the big benefit of using this method is our size limit is much lower. It's 0.01 microns for wet and 0.1 for dry sample preparations. And compared to the MDRS, this gives a wider but less focused view of the sample. So having had a brief look at our techniques and why we'd want to pursue an IVBE, let's look at what our case study was looking at. So the study between the reference and generic products of a mometasone furoate product was completed as part of an ongoing IVBE. We looked at 4 batches of reference product and 3 batches of generic with 1 placebo generic. For each batch, 5 devices were tested under the same instrument conditions. So it's important to take a look at the context here, and we're looking at the very small range of around 3 microns and below. And you can see from this microscope slide that the API and excipient, when they're large particles, are very easy to distinguish. But as we get smaller, it becomes harder to distinguish. And as you can see here, we still have some excipient particles in this example graph below where the API dominates the percentage of particles at that size. So we need to be able to remove these, and we can do this quite easily down to 0.5 microns with the MDRS using the morphology and Raman components. But laser diffraction doesn't have this function, so we need to use the placebo to confirm the identity of the particles in the superfine size range. So we did our MDRS analysis, and this is our classifications for API particles under and less than and equal to 3 microns. And as you can see, we've got the size percentiles here of DN10, DN50, and DN90, and this is the percentage of sample is under a certain size. So for DN10, it's 10% of the sample is less than X size, and so on and so forth for DN50 and DN90. So when we look at our results here, we can see generally a good agreement is visible between the reference and test product. And this we can prove by the statistical analysis via population bioequivalence. Now, when we look at our laser diffraction results, this was a method developed on this project using the reference batches as per FDA guidelines. What we saw here was that the percentiles for the whole sample are much higher for both products when compared to the MDRS due to the lack of specificity versus the filtered morphology slash MDRS results. And this shows the impact of the excipients present in the product. In the range less than and equal to 3 microns and below, there was some difference as well between the percentage of sample particles below 3 microns, with a greater percent of particles existing in this range for the generic versus the reference. However, down to 0.5 and above, below 3, this is all observable by MDRS, where we've demonstrated the API bioequivalence. Therefore, this difference must be due to excipient particles. Therefore, we must prove the difference in the particle size within the range of interest is down to the excipient existing, and therefore not our lack of specificity. As the previous slide showed, the two techniques showed difference in the PSD, and this is due to the lack of specificity in the laser diffraction. Looking further into the data, we can see that the reference batches show no presence of particles below 0.5 microns, and the test batches do show some particles less than 5 microns. However, for both reference and generic products, the percentage of particles less than 0.5 microns is below 0.1% of the total particles. Furthermore, the placebo batch of test products shows presence of the excipient at a comparable percentage to the active batches, and therefore we can conclude that the lack of specificity at this size range is a non-factor, as the placebo batch shows that at less than 0.5 microns, only the excipient particles are found, and so the lack of specificity has no considerable impact on the bioequivalence of the products. So our conclusions from our case study were that characterization of particles under 3 microns by MDRS showed bioequivalence between the reference and generic products. Laser diffraction was then performed on the same batches, which demonstrated that less than 1% of the total particles present in both the reference and generic products are below a particle size of 0.5, and that for the generic placebo batch, this contained a comparable and actually the most amount of particles in that range, and therefore we can conclude that only excipient exists in this size range. With this totality of evidence, we can see that the API particles above 0.5 can be sized by MDRS, and laser diffraction can be used to account for the remaining particles, which are demonstrated both to be an insignificant proportion of the sample, and that this fraction only contains excipient particles, and therefore we can prove bioequivalence for all our API particles. So thank you very much for your time. Please feel free to contact me if you have any questions about today's content.